All right, this briefing will cover the core, practice-changing updates from the 2026 ESPGHAN position paper on pediatric non-variceal GI bleeding. The sole objective here is to give you actionable intelligence for immediate clinical application.
Okay, let's get right to it. The single most significant update here is the introduction of the Sheffield scoring system. Now, this is a major development because it's the first validated pediatric-specific risk stratification tool. Its entire purpose is to improve our pre-endoscopic assessment right there in the emergency setting to pinpoint which children need urgent intervention.
So that brings us to our first section, guideline updates and risk stratification. We're going to break down the specifics of this new clinical tool right now.
So how does the Sheffield scoring system work? Well, it's a pre-endoscopic tool designed to be used on admission. You'll see it assigns point values to key clinical and lab parameters, things like tachycardia, low initial hemoglobin. These are statistically weighted to accurately differentiate patients who will need endoscopic hemostatic intervention from those who won't. The model is optimized for high predictive values, sensitivity, and specificity, which makes it a really robust instrument for your decision-making in the ED. Bottom line, a high score flags that patient for early endoscopy.
Next up, Section 2, Initial Resuscitation and Pharmacotherapy. So, once you've stratified the risk, we move straight into the critical initial phase of resuscitation and pre-endoscopic medical therapy.
The initial protocol here is very clear. First, you're assessing and stabilizing the ABCs: airway, breathing, circulation. At the same time, you need to establish wide-bore IV access. Your essential labs are going to be a CBC, coags, LFTs, renal function, and of course, a group and cross-match. Go ahead and place an NG tube for both lavage and monitoring. And for fluid resuscitation, it's important to note that adult RCT data, which is extrapolated here, shows no mortality difference between crystalloids and colloids.
Now let's talk transfusion strategy. This is a Class 1 recommendation, so pay close attention. The strategy is restrictive. You're going to initiate packed red blood cell transfusion only when hemoglobin drops below 7 grams per deciliter. The rationale here is to avoid overtransfusion, which we know can increase portal pressure and, critically, the risk of rebleeding. Your post-transfusion target, then, is a hemoglobin between 7 and 9.
Okay, for managing coagulopathy, the guidelines define very specific thresholds. For platelet transfusion, the trigger is active bleeding with a platelet count below 50 × 10 to the 9th per liter. For fresh frozen plasma, you're going to administer it if the fibrinogen is less than 1 gram per liter or if the PT or APT is more than 1.5 times the upper limit of normal.
Pharmacotherapy needs to be tailored to your suspected etiology, so there's a clear split here. If you suspect a non-variceal bleed, you need to start an intravenous PPI immediately. There are 2 equivalent pediatric dosing regimens supported. You can either use an intermittent bolus of 0.5 to 1 milligram per kilogram every 12 hours or a 1 milligram per kilogram load followed by a continuous infusion of 0.1 milligram per kilogram per hour. On the other hand, if you suspect a variceal bleed, octreotide is the agent of choice. The dosing there is a 1 microgram per kilogram bolus, then a continuous infusion of 1 to 2 mics per kilogram per hour, which will continue for 3 to 5 days, based on adult guidelines.
All right, Section 3 is on endoscopy. And this is where that risk stratification data we talked about directly informs the critical question of timing.
So, the key question is always, urgent, meaning less than 12 hours, or early, meaning less than 24? The new guidelines give us very clear criteria to differentiate between these 2 pathways. Let's go through them.
Okay, so for urgent endoscopy, that's within 12 hours. It's mandated for any patient with high-risk features. We're talking hemodynamic instability despite resuscitation, a need for continuous circulatory support, or large ongoing hematemesis or melena. Now, for early endoscopy, within 24 hours, that's recommended for any patient who needs a transfusion, has an acute Heb drop of 20 grams per liter, or importantly, has a high Sheffield score that indicates a likely need for intervention.
Moving on to Section 4, Hemostatic Techniques for Non-Variceal Bleeds. Here we'll get into the procedural details, starting with lesion classification and then treatment.
Right, the Forest classification remains the standard for risk-stratifying peptic ulcer bleeding. As you can see, the high-risk stigmata, that's your class IA, IB, and IIA, are all associated with a very high probability of rebleeding and absolutely necessitate endoscopic therapy. Class IIB, the adherent clot, carries an intermediate risk, and we'll discuss that one more in a moment. And finally, the low-risk stigmata, IIC and III, rarely rebleed and typically don't require any intervention.
So, when you encounter those high-risk stigmata, mechanical therapy with through-the-scope clips is one of your primary modalities. These devices are especially effective for controlling that localized bleeding from sources like a visible vessel in an ulcer base or something like a DLFOI lesion.
And this is a crucial Class 1 recommendation, so let's be very clear. For high-risk stigmata, your Forest I, IB, and IIA, dual therapy is now mandatory. Adrenaline injection alone is considered insufficient monotherapy. It must be combined with a second modality, whether that's mechanical clips or thermal therapy, to effectively reduce the risk of rebleeding.
Okay, so what about the adherent clot, the Forest class IV? This presents a real clinical dilemma. Do you remove the clot because, yes, it may reveal an underlying high-risk lesion, but it also carries a significant risk of inducing iatrogenic hemorrhage?
The ESPGAN-SGE consensus recommendation here is one of caution. I'll read it directly. Clot removal should be considered only by more experienced endoscopists and/or with support from adult colleagues. The reasoning is that many pediatric endoscopists just don't have frequent exposure to acute GIB, making clot removal a high-risk procedure reserved for very experienced operators. Ideally, you want support from your adult GI colleagues if they're available. Now, if it is attempted, the recommended technique is injection of dilute adrenaline at the clot base, followed by removal with a cold snare.
All right, our final section, number 5, advanced tools and equipment. The guideline finishes by addressing some novel endoscopic technologies and their specific applications in pediatric GIB.
So this really illustrates the evolution of mechanical therapy quite well. On the left, you've got a standard through-the-scope clip. But on the right is the over-the-scope clip system, or OSTC. The key difference is that the OSTC provides significantly greater compressive force and can grasp much more tissue. This makes it an incredibly valuable tool for refractory bleeding, but you have to remember its main limitation. It's generally not feasible in children who weigh less than 18 kilograms.
Next, we have argon plasma coagulation, or APC. Now, this is a non-contact thermal modality. How it works is it delivers energy via ionized argon gas, which causes a very superficial coagulation to a depth of less than 3 millimeters. This is key because it significantly lowers the perforation risk. This makes APC particularly suitable for those diffuse or superficial vascular lesions, like angiodysplasia. And a critical point for pediatric practice is that thin probes are available that are compatible with standard pediatric endoscopes.
So, we've reviewed the key updates from the 2026 ESPGHAN position paper. This brings us to the critical question that you and your clinical teams need to address. How will integrating a validated pediatric risk score, like the Sheffield system, fundamentally change your institution's triage and consultation pathway for acute GIB? Because proper implementation has the potential to standardize care, really optimize your resource utilization, and most importantly, improve patient outcomes.